16, I'll be presenting about glaucoma shunts, followed by Dr. Alokesh's presentation on MIGS. So this presentation of mine is basically intended for people who are interested in starting glaucoma shunt surgery. So I'll be sharing some very practical tips which I have learned over years doing glaucoma shunt for almost 5 to 10 years. So whenever you're starting a glaucoma shunt, it's important to choose the right shunt. I personally believe you should start with, there are no financial interest, but you should start with the valved implant like a Ahmed glaucoma valve, because overall the valved implant tend to have lesser hypotony and lesser hypotony related complications. So you have less choroidal effusion and suprachoroidal hemorrhage. Non-valved implants like the RD or the valve do have a more steep learning curve. So once you're more comfortable with the Ahmed glaucoma valve, then you can switch to a non-valved implants. Coming to also important to find the right indication. These are the common indications we use. Generally, these are patients where your trab has failed or it's likely to fail, like example, neovascular glaucoma or patient with pediatric aphakia, even pediatric pseudophakic glaucoma, because these are cases where trab has a poor success rate. But personally, I believe whenever you're starting, try to choose a simple case, like example, a case with good conjunctival mobility, maybe a pseudophakic glaucoma. You can use a pseudophakic glaucoma and you can do a primary shunt surgery for a pseudophakic glaucoma. Even a neovascular glaucoma can be chosen as the first case. Avoid cases like post-retinal surgery or a patient with a very shallow chamber like eye syndrome or axon-filled anomalies, because these are more difficult cases, especially post-buccal surgery are really difficult cases. So initially don't do these cases, because as you get experience, you can do these cases, because these cases, the conjunctival mobility is poor, the conjunctival healing is poor, so you'll have more difficulty in closing the conjunctiva. Also understand the tool you're using. There are two variants of Ahmed glaucoma valve, the FP7 and the FP8. The more commonly one uses the FP7. As per the textbook, all adults and up to above 14 years of age, you should use the FP7, and in pediatric age group, you should use the FP8. FP7, the size is around 16 millimeter. This is the place where the tube ends. This is the place where you have the flexible plate which contains the silicone membrane, which acts as a valve. So whenever you are handling this glaucoma shunt, avoid putting pressure at this area, because that can lead to damage to the valve. In pediatric cases, you can use the FP8, which is much smaller in size, just 11 millimeter. Also in patients with, in case you're doing an inferonasal surgery where there is space crunch, or you're doing a post-buccal surgery, you're not getting enough space for putting FP7, these cases you can try FP8. FP8 since has a smaller plate, so you are expected to have lesser IOP reduction compared to a FP7. I'll share one example. This is a patient of axon-filled anomaly who already had a failed trab 2 years back in the right eye. Right eye, you can see the vision is 6/12. Left eye was no light perception. You can see superiorly a failed trab, flat conjunctiva with a large PI. Now this is a young boy. Already the pressure are 28 millimeter mercury on 4 medication, very advanced cupping. So in this case, definitely we need to go for surgical intervention. Since the trab has already failed, no point doing another trab again. Personally, I have not used Ologen much, but whatever cases I've done, I've not found it to be great. But yes, glaucoma shunt is a very good option in this patient, considering it's a young patient, axon-filled anomaly, and already with a failed glaucoma surgery. So this is a small video of a glaucoma shunt surgery using Ahmed glaucoma valve. The various technique, I'll just share the technique which I am following for my patient. You can have a limbal-based conjunctival flap or a fornix-based conjunctival flap. I generally make a 2 or 3 millimeter limbal-based conjunctival flap, and we'll do the conjunctival dissection. You try to open an area which is good enough to insert the plate of the implant. Once you've done the dissection anteriorly, you need to dissect posteriorly, create the space for putting the plate of the implant. We are now priming the Ahmed glaucoma valve. Once you inject the fluid, you can see the fluid coming out from the back portion, which indicates that the tube is patent and the valves are functional. In case the fluid is not coming out, this means the valve or the silicone membrane have fused. These cases you have to discard the Ahmed glaucoma valve. So in that case, always keep a backup Ahmed wall whenever you are doing this surgery. Now, plate suturing should be done at least 8 to 10 millimeter behind the limb. In this case, probably I'm doing just 8 millimeter. You can use non-absorbable suture like a 90 nylon. Like I use a 90 nylon. This suturing is extremely important. Suture it properly. If the plate is too anterior, there will be pressure on the suture section. You have a higher chances of plate erosion. Once you have sutured the plate on the two sides, then you cut the tube so that at least 2 to 3 millimeter of tube stays in the anterior chamber. Use a 23 gauge needle to create the track. And I'm using a specially designed forceps to insert, but you can use a normal Mac forceps also. Whenever you're inserting the tube, try to stay as away from cornea as possible. Oh, sorry. I think, yeah. So try to stay as away from cornea as possible, because if you're too close to cornea, you're bound to have a corneal decompensation, because even when the eye is moving, the tube does have some amount of movement and can lead to corneal decompensation. Once you have put the tube, secure the tube properly, cover it with a scleral or corneal patch graft, whatever is available. Corneal patch graft is better because it is better cosmetically. And after you have done that, you can close the conjunctiva using a 80 vicryl suture with a round body needle. Now you can see we are closing the conjunctiva in the continuous interlocking manner. This is a post-operative picture. You can see a very well controlled IP. The bleb was very big. Basically, the patient had a tenacious formation. In case you are having a post-penetrating keratoplasty patient, these cases you have to put in the sulcus because you want to stay away from the cornea. This particular patient already had a vitrectomy done, so we went for a pars plana approach. You can use the Ahmed glaucoma wall with the pars plana clip, but nowadays we don't use it because this is more costlier. You can use a simple FP7 also and put the tube in the pars plana at least 4 millimeter behind the limbus, so it goes straight away into the vitreous cavity. I'll touch about the Aurolof aqueous drainage implant. It's a great addition to the armamentarium because it's almost 1/4 of the price of Ahmed glaucoma valve. So considering in Indian scenario, it's a very good addition. Only thing, it's a non-valved implant, so the technique is slightly difficult and slightly different. If you have to make a much larger section for these patients, and because it's a much bigger implant, you have to make a larger conjunctival dissection. After you have done the conjunctival dissection, you need to locate the muscles also, because the wings of the implant are inserted into the muscles. So the location of the muscles is important. For example, this is supratemporally we are doing, so lateral rectus and superior rectus has to be dissected, and the wings have to be inserted under the superior rectus and under the lateral rectus. Once you have done that, then you can suture the plate using the 90 nylon suture. After that, this is a very important step. You have to occlude the tube using a 60 or a 70 vicryl suture. You can see we are occluding because these are non-walled implant. So you will occlude the tube and you will put the tube inside. So for 1 to 1.5 months, there will be no flow. But by the time, a capsule will be formed along the plate of the implant. And once the vicryl dissolve, the flow will start, and then there won't be any hypotony. If you don't tie it properly and you insert the tube, there will be very bad hypotony and the pressure will be zero, and you will end up with a bad choroidal. So once you have inserted it, we have ensured that it is totally occluded. Then you insert the needle and you secure the tube, and the rest of the surgery is almost similar. You have covered with the scleral patch graft, and then you will close the conjunctiva in a continuous manner. I'll just share this new video which I have recently done. Nowadays, whenever we are doing RD valve, in this case, what we are doing, we are putting some venting slits. For example, you can see I have secured the tube. I have injecting fluid. I can see the tube is totally blocked. It is non-functional. I'll cut the tube. I'll insert it into the anterior chamber. But since for 1 month it will not function, we'll put some slits into the tube anterior to the place where we have occluded and then cover it with the scleral patch graft. These slits will have some oozing of aqueous, so it will maintain the pressure for next 1 month as long as the vicryl is not dissolving and the tube is not started to function. Sometimes in cases like these, like this is a patient who had a failed failed trabeculectomy, is a young boy. In this case, patient developed a cataract. These cases, you can combine a cataract surgery with a tube implantation. So first we have secured the plate. After securing the plate, now we'll go ahead with the cataract surgery. We should not do cataract surgery first, because if you've done a cataract surgery and you have done a vitrectomy, then the eye will become hypotonous. Then securing the plate becomes very difficult. Once you've done a cataract surgery, you have done an anterior vitrectomy because it's a pediatric eye. Then you secure the ports, and then you go ahead with the implantation of the tube. Rest of the technique is similar, but just you have to put the tube slightly longer, maybe a millimeter longer than adult population, because these patients, as the eye will grow in size, the tube has a tendency to retract. There can be multiple complications starting from tube erosion to corneal decompensation and tenacious formation. I'll just share a few. Meticulous surgery is extremely important, because if you are meticulous with surgery, you can reduce the chances of complication, because managing complication in these cases sometimes can be difficult. To reduce formation of tenacious, what we do nowadays, whenever post-operative the pressure goes above 10 millimeter, we start with acrosuppression, and there are studies which have shown that using acrosuppression reduces your chances of tenacious formation. Avoid going inferiorly. In case you are going inferiorly, I always go inferonasally, because infero-temporally, I had this patient where half of the bleb was outside. It's very bad cosmetically, and also has risk of infection. This is a patient where there was no tube corneal touch. Still, patient had a corneal decompensation. So it has been shown that with glaucoma MS-shunt, because of the backflow, sometimes you can have corneal decompensation. So try to keep the tube as away from cornea as possible. Even if it's touching the iris and all, will not matter much. This is another patient where we have corneal decompensation. In this case, we just went ahead and trimmed the tube, made the tube smaller, which helped in the patient. So this can be tried. Just reduce the size of the tube, so to reduce the movement of the tube. In case that this was the aphakic patient, in case you're operating aphakia, make sure it is a well-vitrectomized eye, because once you put the tube, the flow will start from the anterior chamber, and in case there is any vitreous in the anterior chamber, it will come and block. So always, I'll say, always do a partial vitrectomy in case a patient is aphakic or there is any vitreous in anterior chamber. This is another patient where we did a surgery, one-eyed patient, pressure was 52. Post-operative, there was a flat chamber with almost 4 millimeter pressure. This case, we suspected that was a wall malfunction. There have been reports of wall malfunction. So in this case, we went ahead and we blocked the tube using the 60 Vicryl suture. You can see, I'll take another minute. 60 Vicryl suture was used, and we internally blocked the tube to, you can see we are introducing the 60 Vicryl, and post-operatively the chamber was formed and the eye was restored. This is another case where post-operative there was a graft retraction. Sorry, it's no graft. There was a tissue retraction and the scleral patch graft was exposed. In that case, you can take trim the tissue, and then you can take a graft from inferiorly and cover it. So we should be aware of how to manage our complication. And but most important thing, these are very good tools for our armamentarium. Try to be meticulous in your surgery so that you can reduce the complication. But once you have them, you should be actively and aggressively managing them. Thank you so much.